Hi guys, I'm Tia, and today I'm going to be discussing non-small cell lung cancer, or also known as NSCLC. This presentation is going to share NSCLC's risk factors, diagnosis and staging techniques, treatment choices, and nurse roles in its management. So, lung cancer is one of the primary causes of cancer, and NSCLC comprises approximately 85% of all lung cancers. So it's a big deal in the cancer arena. Although it grows a little bit more slowly than small cell lung cancer, NSCLC is often only found in advanced stages. So unfortunately, this obviously limits therapy options and increases mortality and morbidity. Each of the three primary forms, which are adenocarcinoma, squamous cell carcinoma, and big cell carcinoma, have distinct characteristics and treatment requirements. So while squamous cell carcinoma is firmly connected to smoking, adenocarcinoma is more common in women and non-smokers. So let's actually discuss the pathology and subtypes. Um, Adenocarcinoma is the most prevalent subtype and usually develops in the outer sections of the lung. Like I mentioned earlier, it's more common in women and non-smokers. So part of the reason I actually chose this assignment is I had a patient when I was first working as a nurse, and she was passing away from lung cancer. And she was young, she was in her 20s, I think she was like 27. She'd never smoked, never touched a cigarette in her life. And I kind of blew my mind that lung cancer could exist in somebody that young and who'd never smoked, but it was adenocarcinoma was her subtype. So, I remember that one. Squamous cell carcinoma usually actually starts in the central part of the lungs, so it's strongly linked to smoking. Just because when you smoke, all those tobacco carcinogens directly contact that airway over time. They're the first line of defense, right? So that's why squamous cell carcinoma is heavily linked to smoking. And then large cell carcinoma, it's a rare and aggressive type that can appear really in any part of the lung. So it is considered a very aggressive subtype. Each of these has a series of distinct characteristics and responds differently to treatment modalities. So this was a theme I found in my research. You need to correctly determine the subtype to maximize treatment outcomes. You need to do that early on in the process and quickly. So let's talk about risk factors. They can be broken down into modifiable, environmental, and non-modifiable types. Smoking, like we mentioned earlier, is the leading modifiable risk factor. Tobacco smoking is linked to about 85 to 90% of cases. I'll just let that sink in there. I mean, other lifestyle factors like diet and physical activity are also linked to lung cancer, but smoking is like bottom line, smoking is a huge risk factor. Environmental factors include radon exposure and asbestos. Radon is a radioactive gas that's odorless, tasteless, and it seeps naturally out of the ground at fault lines. Um, and it's actually the second leading cause of lung cancer in the US. So that's a really big environmental factor. Asbestos is like this mineral fiber that was used to be used in insulation. And in recent years, they found out that it causes this type of lung cancer. So exposure to old housing or working in construction can also be an environmental risk factor. Now, non-alterable risk factors, age, gender, certain genetic mutations like EGFR and ALK, which are especially relevant in non-smokers. Let's talk about the screening and prevention. So prevention efforts, again, theme of smoking, they focus primarily on smoking cessation. So quitting really reduces cancer risk, even for long-term smokers. Testing homes for radon and ventilating spaces where there are radon fault lines can lower radon exposure. And then screening with low-dose CT scans is the gold standard for NSCLC screening, especially for high-risk individuals, and high-risk individuals are considered those with aged 50 to 80 or have a heavy smoking history. So research shows that CT scans detect smaller tumors earlier than chest x-rays, and that allows for earlier treatment and also reduces lung cancer deaths because these screening methods detect cancer before symptoms. Okay, so early NSCLC symptoms include a persistent cough that worsens over time, chest pain with deep breathing or shortness of breath, and also wheezing, like a wheezing sounds. And that also comes up on nursing exams. So later signs and symptoms include coughing up blood, so hemoptysis, hoarseness, weight loss, and frequent infections. Physical exams that nurses or providers will do will often reveal diminished breath sounds, the wheezing, and potentially clubbing of the fingers. So indications of chronic low oxygen levels. And then diagnostics. Diagnosis starts with imaging, chest x-rays, or CT scans, followed by PET scans to see if the cancer is spread. And then biopsies are obtained through a bronchoscopy or fine needle aspiration. These biopsies confirm the diagnosis. And then genetic testing for mutations like the ones I mentioned earlier, GFR and ALK, will also help guide specific therapies. Staging and prognosis. So NSCLC is staged using the TNM system, pretty standard. It examines tumor size, lymph node involvement, and metastasis to other organs. For NSCLC in stage 1, the cancer is localized and often treated with surgery and sometimes radiation. Stage 2 can include lymph node involvement, so surgery with adjuvant chemotherapy or radiation is common. Stage 3, larger tumors, further lymph node spread. It requires a bit more of an aggressive approach with chemotherapy, radiation, and sometimes surgery, depending on the tumor's spread. And by stage 4, unfortunately, the focus usually shifts to palliative care. And instead of with treatment intent, chemotherapy, targeted therapy, and immunotherapy are now used to control symptoms and improve quality of life. So that kind of echoes another theme from my research while preparing this video. The earlier the stage the cancer is caught, the better the prognosis. Early detection is essential, especially for this cancer. So treatment for NSCLC depends on the stage and genetic profile. Surgery like a lobectomy or pneumonectomy is common in the early stages, so 1 through 2, sorry. Then chemotherapy, agents like cisplatin or carboplatin are used to shrink tumors and prevent recurrence. Radiation therapy can be applied to tumors that are inoperable surgically, or radiation therapy can be used as an additional treatment after surgery. Targeted therapies focus on those mutations I've repeated a couple of times throughout this, the GFR and ALK, and immunotherapy drugs like, I'm going to try to pronounce this, pembrolizumab. Biologic therapies enhance the immune system's ability to fight cancer cells. So each option has unique side effects. It requires careful patient monitoring, careful patient management, and careful patient education. Nursing implications. Nurses are very, very, very important in managing treatment side effects for cancer. So chemotherapy can cause nausea, fatigue, and immunocompromise. So nurses have a role to administer anti-nausea medication, monitor hydration status, and check blood counts to manage side effects and prevent harm from treatment. Then radiation often leads to skin irritation and fatigue. So nurses need to guide skincare routines and encourage rest. And then for immunotherapy, nurses need to watch out for specific reactions like a rash, thyroid issues, organ inflammation. And nurses also play an educational role. They teach respiratory care like oxygen safety, breathing exercises, and pulmonary infection prevention. Education on lifestyle changes and adherence to follow-up care is a really overlooked role nurses play in improving patient outcomes like infection, um, adverse effects, hospital readmissions. So education is super important, and I don't think it's emphasized enough. Let's see. Let's talk about survivorship. NSCLC survivors often deal with lasting physical, cognitive, and social issues. So physically, they may experience a chronic cough, the reduced lung function from surgery or scarred or damaged lung tissue results in shortness of breath and fatigue. And in that same vein, they have a very increased risk of infections due to the weakened lung tissue. Cognitive effects, colloquially known as chemo brain, can affect memory and focus and be really frustrating for survivors who are trying to perform ADLs. And then socially, many survivors, especially former smokers, face stigma, which can lead to some isolation and emotional distress. All survivors face the risk of cancer recurrence. So there's a need for regular follow-up care and ongoing support post-treatment. Caregivers. They often experience emotional strain, physical exhaustion, and financial stress. The emotional burden of watching a loved one suffer, combined with the demands of physical caregiving tasks, they can take a pretty big toll, right? And financial pressures often arise if caregivers are forced to reduce work hours or stop working to provide care. And to support them, resources like respite care and can be really helpful. They offer temporary relief, and support groups can also be super helpful, just as an area where they can talk about concerns with a group that completely understands what they're going through and experiencing firsthand. So each of these options, including like the counseling and mental health support, are really important to help caregivers manage their stress and maintain well-being. Patients and families need to know how to manage symptoms like shortness of breath and knowing when to seek help. Safe oxygen use is a priority, and so is guidance on smoking cessation, eating high-calorie diets, and performing light exercise to support recovery. Nurses need to know how to monitor respiratory complications, manage treatment side effects, and address the emotional needs of NSCLC patients in order to provide comprehensive care. Recognizing that stigma that they may be experiencing, encourage support systems, and also if a patient is experiencing late stages of cancer, nurses need to promote early discussions of palliative care for better symptom management. So I have two discussion questions. First, what difficulties can occur when teaching NSCLC patients to quit smoking? And then two, how can we encourage patients and families to follow up and adhere to follow-up appointments and monitoring after treatment? And then a third bonus question, tell me how to pronounce this word. It's spelled PEMBROLIZUMAB. This is a bonus question for 50 points. All right, thanks for watching. Bye.